that it might be a bone cancer because it can affect the bones, but it's actually a blood cancer and affects these immune cells that live in our bone marrow called the plasma cells. And so plasma cells are the cells that live with us for most of our body and help protect us from external infections. So if you get sick with like a bacteria or a virus, your body teaches the plasma cells how to make a protein called an antibody that blocks these infections from attacking our bodies more than once. So the bone marrow is the soft tissue that's inside of our bones. It's in the hollow space of all of our bones. It's the factory where our blood cells are made, and it's actually an immune system organ. And so the plasma cells live in this blood-rich bone marrow environment for their normal lives, and that's actually where myeloma can develop is in the bone marrow. So as I said, plasma cells are a special type of white blood cell that it can help us fight infections. And when these plasma cells turn into multiple myeloma, they can grow and multiply out of control. They can crowd out the healthy cells in our bone marrow and lead to low blood counts. And this might also be called anemia or low red blood cells. There can be low white blood cells can cause risk of infections, having low white blood cells. And essentially, one of the jobs of the normal plasma cells to make these proteins called antibodies. And they also make the building blocks of the antibodies, which actually these are called light chains. Those can, in very high amounts, cause organ damage by injuring most commonly the kidneys and sometimes nerve tissue. Multiple myeloma can weaken the bones because it has an impact on the way that our bone maintenance system works. It shifts the whole process towards breaking down bones instead of building bone. And so the normal system that helps keep our bones healthy and strong isn't working properly when myeloma is active. It shifts it all towards breaking down bone. And sometimes the first symptom that people might develop when they find they might have myeloma is a bone problem. People might break a bone doing something that they might not otherwise be at risk of a fracture from doing. So it can be one of the first features that shows up. So here's a diagram showing the plasma cells in the antibody and in the bone marrow. You can see they make these blue Y-shaped proteins called antibodies, and when they're in normal numbers, they're in balance with the red blood cells and the white blood cells. But when they start becoming abnormal and take on, in this diagram, this like, purple color, they start growing abnormally. They start crowding out all of these other cells. And they actually make, one type of antibody that we can measure in the blood that's called an M protein. And so sometimes people might have blood tests that show they have a high total protein test, and this could be incidentally discovered when you have routine blood work with your family doctor, and might be the first sign of myeloma or a precursor condition to it. Normally the bone marrow has these cells and they help us fight infections. When things become abnormal, they grow out of control and crowd out the healthy cells and then lead to other problems in the body. So, what are the symptoms of myeloma? We have this acronym, CRAB, which helps us remember exactly what myeloma does. So, it can cause high blood calcium levels, and this is largely from breaking down the bone, which is how our body stores a lot of our calcium. So, it dissolves some of the bones and it leads to high calcium in the blood. Renal failure, or R in the CRAB acronym, is for the kidney function. And so, this is what I mentioned before, where the myeloma proteins can injure the kidneys. And that might also be the first sign of myeloma. People might only feel, fatigued or a little tired, and then getting blood work, they might find that their kidney function has been affected. A is for anemia. Anemia is a low red blood cell level that's due to cancer cells occupying space in the bone marrow and crowding out the usual cells that make the red blood cells. And so sometimes people might find they're very short of breath with minimal activity, things that they used to do without any difficulty, they're starting to get really short of breath doing. That's not really a specific symptom. That could be, really present from a variety of issues, either heart issues or lung issues could also cause you to be short of breath, but that might be one symptom that you find that could be related to myeloma. And lastly, again, bone lesions. As I mentioned before, the bones can become weak and sometimes break and can cause bone pain as a symptom of myeloma. And so, in about a third of patients, we can find that people have myeloma before they have any symptoms just through analysis of their blood work. I would say that bone pain is probably the most common early symptom of myeloma. But we're all human. We all have aches and pains. So, you shouldn't think that every pain that we have is potentially myeloma. But I tend to think that, if there's a new pain that's unexplained, that isn't, really in the joints, but is maybe in one of the bones and is a pain that doesn't come and go, but is a pain that keeps getting worse and doesn't have explanation, this is probably something you should talk to your doctor about. Not necessarily would be specific for myeloma, but find that kind of pattern of pain to be a worrisome one that needs more investigation. So, thinking about how we diagnose myeloma, when you would meet with your doctor, we could send blood tests and urine tests to look for signs of these extra proteins or for low red blood cells or high calcium. If we have suspicion for myeloma based on some of the blood tests or the urine tests, we like to check the bone marrow as a really specific way to look for myeloma. And this is something we can use by doing a biopsy there's an area in the posterior hips, which is relatively easy to do. It's a place where the bones can be quite close to the skin. It's an outpatient procedure that we do that can try to help us understand the possibility of a patient having myeloma by really getting a good analysis of how many plasma cells they might have in their bone marrow. Are there a normal amount of plasma cells, or are there potentially a lot of plasma cells there? We can also look into the biology of some of these abnormal cells by sending tests called FISH, which uses some fluorescent labels to highlight what kind of chromosomes these cells have. And so sometimes we find that the DNA or the genetic material in the plasma cells is abnormal. People have patterns of extra chromosomes or missing pieces of chromosomes, and that can kind of help us understand how a person's myeloma may behave. There are other tests using DNA that we can do to look at do DNA tests of the plasma cells to see if they're missing some important genes or if important genes that help our body fight cancer are mutated. And another important issue is imaging tests are very important for looking for myeloma. So this is really how we would find out if people have potentially bone damage from myeloma. And so there are some whole body x-rays, or this is also called a skeletal survey that could be done. X-rays are not the most sensitive tools, so I think that we really lean on some of our more advanced imaging techniques if we're trying to make a myeloma diagnosis. Sometimes we use a whole body scan called a PET CT scan, which can do like it's like a whole body CAT scan that can give us good pictures of the bones, and the PET part of that can help us understand if there are abnormal cells that are growing. So, what about the prognosis of myeloma? So, myeloma is a type of disease that has really had a really amazing amount of progress that's happened in the last 20 years through the development and the discovery of new drugs that work for myeloma, and the study of these drugs in combinations have led people to have remarkable long survival with myeloma compared with what we used to have like in the early 2000s. So I'd say, on average, the amount of survival time with myeloma is in the range of about 10 years. But I would say that for some of these high risk versions of myeloma, it can be shorter. And unfortunately, at this point in time, we don't think we have a cure for myeloma. So despite having a lot of strong and effective medications that get rid of a lot of myeloma cells in the body, we do find that most patients have their disease become resistant to the drugs that we have, and then the disease comes back, and we need to choose a new set of drugs to try to treat. And so one of the things that really is exciting for me in my work treating patients with myeloma is I am very active in clinical trials where we try to find new drugs for myeloma and try to study new drug combinations. These might be drugs that we know already work for people in myeloma, but maybe haven't been studied in this exact combination. We also study new drugs in myeloma that have potential to impact the disease in a positive way. So when I meet with patients and we're talking about a new myeloma diagnosis, and they ask me the question, Doc, like how long do I have to live? I tell them I really don't know because if someone asked me this question 10 or 15 years ago, I would probably say something different without knowing what kind of tools I have in my toolbox today. So I think one of the reasons I became interested in myeloma is really all the progress that has been happening so far, and that's really continued. where, I've been treating myeloma at U of M since about 2018, and I'd say that I do things differently now than I did then. Um, Dr. Edwards, did you have a question?
Yeah, I was just wondering, and there was a question in the chat, and I think this is a good question. Is like, what percentage of the population suffers from myeloma, or you can talk about the stages of myeloma and what percentage suffer from each stage, but like, what percentage of the population generally sort of has myeloma?
That's a great question. I actually have a slide for it
Awesome, I figured.
in about two slides. So,
And then there
um,
was, just in case, there was a follow-up question which I thought was interesting because I hadn't even uh, someone asked, does AI help interpret the images? Which I thought was an interesting question because it's really, there's some aspect of AI that's used in lots of radiologic procedures and lots of reading of images, and almost all of these have a radiologist that sort of reads over them. But I think it's interesting to hear how is as you go through your talk, you might consider how has AI impacted any of the work that you're doing and any of the diagnostic or treatment protocols that we're thinking about.
it's a great question. So, I mean, I think AI has been a really exciting development, but I'd say it's still, such early days in really being able to apply AI. I'm not aware of any immediate, clinical use of AI for interpreting radiology images. But certainly, I think people are studying this, and I haven't necessarily in our work seen that we're using AI to try to find bone lesions from myeloma, but certainly I think it'd be an interesting application of this to try to leverage developments in AI for like really making clinical decisions and looking at clinical data. But I'm absolutely sure there's more to come on that, but I don't think we're
I
quite
know.
there yet. I mean, I think at this point in time, I'm using a little bit of AI in my clinic as a pilot for helping me write my notes,
Notes.
engage with patients, so I can really talk to the patients and engage, and really engage with them rather than focusing on trying to do a lot of typing during the visits. And it's really been helpful for that. But I think there's much more to come. I think that there has been. And I think applications both for clinical care and research, there's a lot more to come from this in the future. So
I'm gonna distill some of the doctor conversation we just had. So when we talk about using AI for notes, and I giggle because I'm like, I just finished a clinic day where I've got a bunch of notes to finish, right? And when Dr. Pianco is talking about doing AI for notes, it helps us as a tool to be able to kind of look and talk to the patient and do our physical exam and really have conversation and think about what the next steps in treatment are without having to so much worry about, did I write all of those details down, and is it going to take me an extra 20 minutes to close this patient note? And it really allows us an opportunity to sort of engage with patients more than sort of typing as we're trying to get the history, or finding an exam finding and then running to the computer to document that. So I appreciate that it's evolved in your office as well.
Yeah, it's been a great, I think, time-saving tool to generate a draft of a note where I'm, know that it's really helpful capturing the details that I want to capture. But at the end of the day, I still have to, do some editing to finish it. It's a useful tool for time
100%.
saving, but I think that
Absolutely.
there's so much more to come in that. So.
Yeah.
Um,
Thanks for
so
that.
yeah, thank you. Thank you for the question. So I think survival varies a lot by the risk of the disease and access to high quality care. I think there's been a lot discussed about disparities in care for myeloma, but that if you have equal access to the treatments, that people of varying backgrounds do equivalently well with this. So I think really about the biology. If you have good access to treatment, I think people can have really great outcomes with this, and I think it's an really important feature in trying to make sure that we get great access to care for all of our patients with myeloma. We know that early detection and starting treatment promptly can lead to better outcomes. And I'll talk some a little bit later about screening and trying to think about how we deal with risk factors, trying to stay active, maintain a healthy weight, since we know that obesity can be a risk factor for myeloma. And we do think that there's a lot of ways that we can lead patients to live fulfilling lives while managing their myeloma, even after diagnosis, and have good quality of life for a very long time. So, here are some of the risk factors for myeloma. We think older adults are most at risk. It is a disease that's more common in older adults. There are some environmental exposures that we know are risk factors for myeloma, and I'm sure there's a lot that we don't know yet and are worthy of more study. We know that there's some small role of family history, that there's some patients in whom there can be multiple family members who have myeloma, and potentially some role of genetics in the development of myeloma. Racial and ethnic factors that might play a role in the incidence of myeloma, as well as obesity. So, myeloma is the second most common blood cancer, and most second most common cancer of the blood in adults. These data are a couple years old now, but we've seen about probably 35,000 new cases roughly each year of multiple myeloma that are diagnosed in the United States. As our outcomes improve, there are many hundreds of thousands of people who are alive with myeloma today because many of our developments have turned myeloma a lot like into a chronic disease. It's about 1.8% of all new cancer diagnoses in the US. It's most commonly diagnosed in older adults and people between the ages of 65 and 74, and the average age of diagnosis is about 69. So we know that the incidence of myeloma varies by race, ethnicity, and gender. So here's a figure showing just with men on the male on the left, female on the right. We can see that the various rates of myeloma per 100,000 people. So if you look about all races for men, there's about 8.7 cases per 100,000 in men and 5.9 in women. And you can see just looking at the different racial and ethnic groups here that it seems to be more common in non-Hispanic blacks compared with other ethnic groups. About twice the risk of a black person developing myeloma compared with someone who's white. There's some other groups that have an even lower risk, such as Asian Pacific Islanders, and it's a slight predominance towards men over women in general. And we, know that blacks really have the highest rate of myeloma of any race and ethnic groups, race or ethnic group in the world. And looking at the U.S. myeloma population by race and ethnicity, the pie chart here shows, but probably about 65% of patients are white, 19% of patients are black, 10% Hispanic, 5% Asian, and then we don't have data for about 1%. This is a different way of demonstrating that data, showing that the rate of developing myeloma is about double in African American compared with white populations. How about what about Michigan? So from 2017 through 2021, each week there's estimated to have about 16 people in Michigan who are diagnosed with myeloma each week. There were about 4,270 cases of myeloma diagnosed in this time period, a little bit less than the average per 100,000 across the US. So about 6.5 cases age adjusted per 100,000 people compared with 7.1 across the United States. And from 2018 through 2022, there are about 2,225 deaths from myeloma, and the death rate a little bit higher than the national average, three age-adjusted deaths per 100,000 being the U.S. average. So some research on myeloma. I've had some collaboration with a colleague at Michigan State, Dr. Jamie Bernard, and she's a toxicologist and has had some interest in looking into the biology of how obesity and potential other exposures might impact development and risk of multiple myeloma. So she did some work looking into obesity and found that there are some factors produced by fat cells that can stimulate the myeloma cells to grow through activating something called the aryl hydrocarbon receptor. So this is like a lock and key system on the surface of our cells, which can uh, bind to things that are made by fat cells that can actually promote the growth of the myeloma cells. So when this pathway is activated in the cells, we find that the myeloma cells seem to grow and survive a bit more. This is some work that we worked on together that was recently published, and she's continuing her and Dr. Jonathan Diedrich, who's a trainee in her lab, who now has his own lab, has also been interested in myeloma, and these are some of my Sparty colleagues down the road at Michigan State who I really enjoy interacting with. So what do we know about environmental hazards in the community? We know certain chemicals used in the manufacturing industry can promote development of myeloma, exposure to radiation and certain herbicides and pesticides, occupational exposures through such as farming or petroleum work, manufacturing might carry risk of myeloma. And there's also been a question about water and air pollution in some communities, which I know is a topic obviously near and dear to the hearts of everyone on the call. I think there's a lot that we really don't know, but I'd like to talk some more about these. We've known from a variety of studies looking at risk factors for blood cancers that patients or people who have worked in agricultural communities are at higher risk of developing myeloma. Oftentimes it's actually quite difficult to prove exposures to cause cancer as a general question, really for any type of cancer. Sometimes you have people who are exposed to a certain type of chemical or product decades before they develop a disease. And it's just logistically very hard to prove what people are exposed to years and years ago when the outcome of interest happens decades down the road. So I think we rely on large population studies, survey studies. Some countries keep better records than we do, such as like the Nordic countries have these huge registries where they track every single case of myeloma, and there's been a lot to go back and look into risk factors for developing myeloma. Um, there are some exposures that we definitely know are risk factors for myeloma, such as Agent Orange was an herbicide used in the Vietnam War to clear large swaths of jungle. We know that through epidemiologic studies of veterans that people who got exposed to Agent Orange or potentially who were stationed at Camp Lejeune are have risk factors of developing myeloma. And actually, the VA, you can apply for VA benefits, and the VA will pay for all of your myeloma treatment because of your service-related development of the disease. Exposures to radiation. There's been some data for various sorts of aromatic hydrocarbons or chemicals that might lead to development of myeloma, such as benzene, toluene, xylene, vinyl chloride. Certain other occupations might be at risk, such as firefighters. They did a study looking at 9/11 World Trade Center first responders who were in the rubble at the World Trade Center had higher rates of developing multiple myeloma and its precursors. And there's been some other data looking at air pollution, like fine particulate matter, promoting the development of potentially of myeloma. In terms of the water crisis at Flint, as you all have discussed many times before I ever joined you here, really the primary contaminant was lead, and I think that I understand that some of the questions that led to my invitation have been, community members discussing, interest in myeloma, about if there's any sort of connection between myeloma. I think that there's really not clearly evidence right now that there would be a link to myeloma, but I never say that anything's impossible. I think that this is a question that is very difficult to study, and I think is worthy of more study. So I don't say there's no connection. I just don't think we have evidence yet of any kind of connection. And I think all I can really talk about, today is sort of what we do know about the risk factors for myeloma. But I think certainly there's more that we need to learn, and I know many here on the call are thinking about it, that and efforts to try to work with the Flint community to understand what sort of might be risk factors for development of cancers and other health conditions in the community. So another exposure definitely of interest in Michigan is PFAS, these sort of forever chemicals that have led to various water contamination in the state. I think there's been mixed evidence showing a link between myeloma and PFAS. There hasn't been a clear connection, but I think many of the studies have focused on leukemia and lymphoma rather than myeloma. I think this is something that really is also worthy of further study, and I don't think we have enough clear evidence to show a link at this point.
Why do you think the studies have focused on leukemia and lymphoma as opposed to myeloma?
So I think that I don't know, but I can hazard a guess. I think that sometimes our registries for cancer were built to capture leukemia and lymphoma, and many times there actually has not been an entry for multiple myeloma, where we think about myeloma as kind of like a subtype of lymphoma, and I wonder just whether the uh, data was captured properly. Is everyone hearing me okay? I just wonder if my screen froze. Hi there. I think my screen froze for a minute.
Okay.
I apologize. Everything went
That's
quiet. So
I heard
No.
you.
I think myeloma was really on the epidemiology, databases. I think it hasn't always been its own category because it's thought of as a less common malignancy, and so I think sometimes just the way that the data is captured has led some of these questions to be more easily asked of leukemia and lymphoma rather than myeloma. I don't think it's a good answer, but that's my guess, I think.
Yeah. I think your answer sort of illustrates kind of one of the comments in the Q&A that I want to at least recognize. So there, one of our community members is describing having a close friend who was diagnosed, didn't seem to kind of fit the picture that we're typically used to seeing, didn't have any of these environmental exposures. And the need for us to be a little bit more robust in our research and kind of potential causes, because sometimes there are cases that sort of don't fit the mold. And so I think you kind of hit it with saying sometimes we're not always looking or tracking, and thinking about multiple myeloma as one of the indicators we need to be following. There was one more question that kind of came up, which was you mentioned this pretty stark difference between myeloma as it presents in the African American community, and the numbers versus white community. And I wondered if there's any obvious reasons or any postulates about why that is, and things that we can be thoughtful about as we screen, and think about prevention.
Yeah, I think it's a great question. It's a difficult one to answer that probably has multiple
Mhm.
different reasons in different people, but there's probably, aspects of some some health access to testing. Sometimes there may be higher rates of certain chromosome abnormalities in individuals of African descent where this type of myeloma has like a fusion between chromosome 11 and 14, just tends to make more proteins, and sometimes those types of myeloma just cause more kidney injury. I think there's a lot of reasons that we think I really don't know, but I think that we do see differences in how the disease presents,
Yeah.
and I think that at least I think heightening awareness of this as a potential issue is important so that, sometimes if you get blood work and, you're just, I think engaging with your physicians to understand, like to do general health maintenance is key. And like, I think to ask, the right questions or to have an awareness of the disease. Because I think that many times we don't really, many people I meet who develop myeloma said, Doc, I never heard of this until someone told me I had it. And, I think it's a great question.
Yeah. Thank you so much. I think there's some element of exactly what you said we can postulate, right? Is screening and prevention and awareness. And just like several of our other disparities kind of present access to care, all of those barriers to care that often present in communities of color. Those would certainly impact sort of availability of diagnosis, certainly our social determinants of health, right? You kind of suggested this with some of the data you've presented. If your exposure risk is higher, right? If your potential to encounter any of these risk factors is higher, then certainly we would expect those results. So appreciate you giving us some context.
Yeah, yeah. Thank you for the question. Um, so, um, touching a bit on family history and genetics. So, people who have a first degree relative with myeloma have an increased risk of myeloma, probably about twice to 2 to 4 times as likely as just someone in the general population. It's not an enormous risk. There are some cancers in which, if you have a first degree family member with, let's say, a genetically inherited either breast cancer or ovarian cancer, the risk can be many, many times more. So we think that this is a small risk. Most people who have myeloma do not have a family member affected, but family history of other blood cancers could increase the risk. There are certain genetic mutations that might predispose some families to developing myeloma, but I think largely these are still in the area of research. So this isn't necessarily something I could send a genetic test for a family member or a patient of mine to say, when I get this question all the time, which is like, Doc, are my kids at risk, or is my, do I have any family members who might be at risk? Like, what should I tell them? And I think, it's important to have an awareness of this, but there isn't necessarily testing that we would do for as like a standard approach for people who have myeloma and their family members. This kind of brings me to the next point, which is like screening for plasma cell disorders. So currently there are no guidelines, national guidelines for routine MGUS screening, which is MGUS is a acronym for monoclonal gammopathy of undetermined significance. It's a precursor to myeloma in which we find evidence of this abnormal antibody in the blood work, but it carries a very low risk of progression. It's about 1% chance per year of developing myeloma, and it's actually quite common. So about 3% of adults over the age of 50, we think have MGUS, and this number increases with age. So, we do testing to look for myeloma, you have to think about the group of people you're doing this testing in. You might have a high chance of finding a precursor to myeloma, which may be helpful because you can follow people and try to have early detection for when it might become myeloma. So for people who are diagnosed with this condition, MGUS, we follow regular monitoring. So usually do blood work like such as once 6 months after we find the initial M protein, and then maybe once a year to make sure that their blood work remains the stable and they're not showing signs of active myeloma. There is some research looking into screening. I'll talk about a couple of those studies here. iStop MM is a trial that I'll talk about where they did a population-based screening for monoclonal gammopathy uh, type conditions, which can develop into myeloma. And then, these sorts of studies impact whether there might be screening for high-risk groups, such as those who are African Americans or those who have a family history. So the iStop MM trial is this amazing trial they did in Iceland, where they basically screened like the whole country of Iceland for myeloma in like 6 months. So they invited over 80,000 people over the age of 40. I think in like 6 months they enrolled like 60 or 70,000 people for testing, and they did screening to look for myeloma and found that about 3% of adults over the age of 40 may have MGUS. It's maybe more common than previously thought. We think what 1% per year patients will progress to developing myeloma, but most people who have the precursor condition will never develop myeloma. So we know screening can find people at risk earlier, but we don't necessarily have a cure for this disease right now. So it would likely just lead us to
Mm,
monitor patients, which we found that if we know someone has MGUS and they do monitoring, they have lower rates of organ damage from myeloma when they do develop myeloma because we can find out that the disease is moving earlier than if we didn't do any more testing. So we know, so at this point in time, our current recommendations, we're monitoring people of MGUS, but we're not yet doing widespread screening for the general public. So this isn't something like colon cancer where you start getting a
mhm.
colonoscopy at a certain age, or breast cancer where you start getting mammography at a certain age. There isn't yet a screening program for myeloma at this point in time. There is a research study that's being done based out of Dana-Farber Cancer Institute in Boston, led by Dr. Irene Gobriel. And so this is a study that patients anywhere around the country can sign up for online and see if they qualify for screening. They're looking for high-risk individuals, like I mentioned before, people who are African Americans, age 30 or older, or those who have a close relative with myeloma. So you could go to, just Google this study or go to the website and look around to see if you're interested and you might qualify or know someone who might qualify. But basically, U of M doesn't have anything to do with this study, but I'm just bringing it up because I think it's a neat effort to look into screening, high risk individuals for myeloma. I have another question in the chat about how expensive is the test. So,
Yeah.
for this study, I think it's all provided. So, otherwise, I think
I think
that
that,
most of these
oh,
are covered by insurance, the
right.
general, testing for myeloma, and I think the amount that it costs, varies
Insurance copay.
by the insurance company as to like what it ends up costing. Yeah.
So I think this question came in before the screening. So I was thinking, one, this would be something that your primary care doc would probably get like a regular CBC first, right?
Mhm.
Before we ended up doing a significant workup. And
Correct.
usually that's usually has a fair amount of coverage, isn't something that we typically have a lot of trouble getting covered. And usually it would have to have a diagnosis associated with it. So maybe you present with some symptoms, and that's the reason why we're getting the CBC. Um, but there were a couple follow-up questions, Dr. Pianco, around there are several follow-up tests for myeloma. It's not like you get one test and it's diagnosed. And I'd wondered if you'd talk a little bit about that and what it means in terms of time to diagnosis and detection.
Yeah, great question. So, as you mentioned, the testing for myeloma is often in response to something. So you need to get regular blood work with your doctor, maybe, and they find anemia, and then a test to look for why the red blood cells are low might lead to a myeloma diagnosis by sending these other tests. Or if there's a unexplained kidney problem, it'd be a common reason why people get this
Mhm.
testing. Or if the total protein levels are high in the blood for some reason. Sometimes unexplained neuropathy is another way that we send testing for this that can lead to the diagnosis of myeloma. So um, I think that the since the precursor to myeloma is pretty common, generally speaking, um, the rate of progression is pretty slow, like 1% per year. The time varies by people. We don't always have to do a bone marrow biopsy in every patient who has an abnormal protein in the blood. If they have a very
Yeah.
low amount of protein and no risk factors, we might follow that patient without doing the more invasive testing. If someone has a higher risk of having a more advanced plasma cell disorder, there are actually some tools that can help us predict that by plugging in. This iStop trial made a calculator that I can plug people's numbers into to try to help predict whether or not it's worthwhile doing a bone marrow biopsy in that person. And so oftentimes it takes, several months to do this kind of testing. You might get a first set and then say, oh, this looks a little bit abnormal, but I'm not sure if it's really abnormal. It might be an indeterminate test. And I'd say, let's just repeat this test in 3 to 6 months and just be sure
Okay.
it's, not something that's like a response to a recent illness. Sometimes the testing can look abnormal. If you just got an infection with a virus and are recovering from that, you might have an abnormal protein electrophoresis test. So I think you want to establish whether or not it's real and whether or not you've got any other reasons to move faster, such as
Yeah.
if people have anemia. If you've got any of those crab features that I mentioned before, like anemia, high calcium, kidney dysfunction, I like to move more quickly and repeat blood work soon. It still ends up taking a couple weeks to, a month or so just to get people back in the clinic, repeat to get them talk about the
Yeah.
biopsy, get the biopsy scheduled. Biopsy results take about 2 weeks to get, the results back after the biopsy. So it takes a little bit of time, but
It can take some
I
time.
think there's reasons that make me hustle but then there's other reasons that make me I can understand if I'm less worried about a particular person.
Yeah. I appreciate you saying that because I think, the time between an abnormal blood test and doing a bone marrow biopsy might differ. And bone marrow biopsies aren't without their own risk, right? So it's helpful to understand that people might, you know, providers might work with patients to decide to watch labs for a little bit and actually understand kind of where the progression is going, or might go to a biopsy sooner, but that depends on some of those features that you've described.
Thank
It's
you.
really, yeah. There was one other follow-up question that was that you mentioned um high risk and black populations fell into the high risk, but there was a question about whether male populations fall into the high risk because of that difference in prevalence.
Yeah, so there is some predominance of men over women. I can just like try to zoom back to that slide so we can look at the predominance here. So, 8.7 men per 100,000 versus 5.9 women per 100,000. I don't think we really understand the gender reasons for why there's a little bit more men than women. So I don't think it's rare in women. It's just there. It seems like if we just look at the balance, there's a little bit more in men than women, and I don't know why. I don't think we know why at this point.
Yeah.
Um, so getting back to where we were, I think we were talking about the Promise study. It looks like to pull up the chat. It looks like we had at least one participant who did participate, Madeline,
Yeah, you had a participant.
and
And they said due to hearing your talk before.
oh, great. Well, I think it's a great study. So if you're interested, check it out. So how about treatment of myeloma? So there's a lot of different treatments that we've had. Here's some just general categories. We've got some immunotherapy treatments, some oral drugs like lenalidomide or Revlimid is the other name for that. Proteasome inhibitors, these are sometimes injections or infusions that, block things in the cells, the myeloma, that myeloma cells really like to have working well, and they're really dependent on. So some of these are like, they're like targeted therapies. It's not really truly chemotherapy like, is used to treat many other types of cancer. These are special drugs that really only work in myeloma. We sometimes do stem cell transplants in which we give a high dose of chemotherapy to kill myeloma cells and then give people back an infusion of their own cells, bone marrow cells afterwards to try to help them recover from that. We have immune therapies. We give a lot of supportive care, some medicines to try to strengthen the bones and keep the bones from breaking. Some of these are the same kind of drugs used to treat osteoporosis. We just give them more often in myeloma. Kidney, support, really trying to avoid things that hurt the kidneys. Ibuprofen, other over-the-counter pain meds. We try to have our myeloma patients avoid those if they can. Working on infection prevention and clinical trials, another route for exploring possible treatment. So, our team, has, for caring for myeloma, there's a variety of people involved. I work with a very close team of colleagues, nurses, pharmacists, orthopedists for people who might have bone issues, social workers. There's some wonderful support groups in the area that are organized by the International Myeloma Foundation. I think the Flint support group had recently merged, I saw for the website, with the Ann Arbor support group, and they're largely doing a lot of their stuff online. So we have some great contact with them. But I think there's a lot of networks out there, other foundations such as the Health Tree or the Multiple Myeloma Research Foundation that could be sources of support or learning about myeloma and its precursor conditions. So covered a lot. Sorry if I talked a little bit longer than maybe
No.
I was allotted, but I think this is just a great introduction to myeloma, and would love to engage with anybody here to answer questions or to better understand myeloma and what we can do to fight this disease and try to maximize like life and quality of life for our patients and for our communities. So let me know if there's any happy to answer any follow-up questions. And thank you again for the invitation to speak. It was wonderful to be here with y'all today.
No, we appreciate so much the wealth of knowledge you shared with us today. Like it really helps us understand kind of the scope and what we should be considering, both as thank you to you as a provider, as I've learned something, but also as people in the community who have loved ones who either are suffering with myeloma or might have risk factors for myeloma. Getting some of that context has been super helpful. I wonder if you have any, from your perspective in a research space, if you have any thoughts about what is on the horizon for research. It strikes me that there are a lot of spaces and places that we have unknown still in myeloma. And what
Mhm.
do you think is on the cusp, or what do you think is coming next as we examine more and we look to learn more about myeloma research?
Yeah, well, I can speak to some of I think what's really interesting in the treatment of active myeloma right now is like development of a lot of immune therapies that really help our immune system attack and fight myeloma cells. The myeloma cells become abnormal in such a way that the immune system can recognize them as being like a foreign invader. So there are some drugs that can be used to teach the immune system to fight myeloma. I think where it would be really fascinating is like how these might develop into ways in which if we could find myeloma before it develops and try to teach the immune system to get rid of it before it causes myeloma,
Yeah.
that could really do a lot in terms of trying to avoid, long-term, needing to fight myeloma for years and years. Right now we have lots of drugs, but they all stop working at some point, and people need to be on treatment for years. And usually, starting myeloma treatment, you start continuous treatment, and we give drugs until they stop working, and then we try to switch the drugs. And so I think, wouldn't it be wonderful to try to, screen for myeloma and try to evaluate whether we could intervene early in the stage of the disease before it becomes something that we think is not curable. But I think that I hesitate to say it's not curable. I think it probably could be curable. I think we just maybe don't know how to do that yet. And
Yeah.
I'm hopeful that some of these approaches using the immune system could get us there. Other ways I think that would really be, important to know about is, really I think the understanding like why does myeloma develop is an important question that we have to better understand. So there's some risk
Yeah.
factors related to things we can't change, such as our, just our genetics and the bodies that we're born into, over time, there's a random chance you get myeloma or any other type of cancer from, DNA damage, from things we're exposed to throughout the course of our life. But are there things that we can learn about that might help us reduce the chance of developing myeloma? So are there other exposures that need to be, identified and, regulated in some way, or like, there are things in our water supply, or there are things that are, environmental contaminants, or there or
Sure.
herbicides or pesticides that are used for like industrial farming that we like shouldn't be using because
Right.
of maybe some low risk of developing blood cancers. But these are, I think, consistent findings that there are risks to agricultural communities from use of some of this stuff. And so I think that further study of the why this is and what could be implicated, I think, is important.
Yeah. Hey, Dr. Pianco, super, super appreciate you for your support and your time and your expertise today. I want to bring Dr. G up and Nurse T. Mostly, Dr. G, I know you have so much collaboration with the American Cancer Society and some of our local resources, and I wondered if you had any last second additions that you wanted us to think about as we're considering multiple myeloma.
Was that for me? Oh, thank you. It's very good information that was provided, especially for the veterans, because I lost an uncle to multiple myeloma. He had Agent Orange.
Mm,
And also myself, I went through the process because I fractured like my fifth metatarsal. And
mm.
on the MRI, it showed that there might be some type of lesion, but I went through all the tests and thank goodness it was normal. So this is some excellent information that provided. And I did also I put in the chat for, I think it's not showing up disabled, but for veterans, how they can reach out to apply for the Agent Orange or Camp Lagoon. So thank you for this very important information on the signs and symptoms. And also, can you about the age? What is the average age again for? I know African American Court and American Cancer Society is usually like 5 to 10 years earlier than our Caucasian counterparts or other races.
Yeah, I think it was about 69 is the average age of diagnosis of myeloma across all ethnic groups.
Okay, thank you.
Yeah.
That's all I have. Wonderful presentation.
Thank you so much. I appreciate that. And
Thank you
I'm happy
both.
happy your foot thing ended up being
Yes, it was.
not that,
Yes,
and I'm sorry
yeah,
for your loss of your family member.
yeah. Thank you so much.
All right. Thank you both so much. This is wonderful expertise, Dr. G. We always appreciate you bringing the local context and helping out the veterans and always appreciate your expertise as well. Thank you. Thank you. This is a wealth of information. And we hope whenever someone has done such a wonderful presentation, I'm going to warn you, we bring you back. So
I would love
expect
to
to
come back.
hear.
Thank you so much.
All
Thank
right.
That would be great.
Awesome.
And thank you again so much for the invitation and for all the important work that you all are doing. And let me know if there's anything I can do to help you all in your goals.
Awesome. Super
thank
appreciate
you.
that.
Thank you.
Um, as we think about research, emerging trends, emerging ideas that we need to present to the community, no one better to talk to us about how we do that in Flint than Dick Sadler to talk to us about the Healthy Flint Research Coordinating Center and our 2025 Research Symposium. So, Dick, my wonderful colleague, I'm going to let you take it away.
Yeah, thanks. So I'm Dick Sadler. I'm an associate prof here at Michigan State's Public Health Building. We just had a big boom of thunder outside. So if I jump, that's why, for those of you that aren't in Flint and hearing the same thunder. So yeah, our eighth annual Healthy Flint Research Coordinating Center Symposium is now 11 weeks away. It's on Friday, September 26th at the Riverfront Conference Center. And so two pleas or requests of all of you on the call here. If you are involved or engaged in research, either as a researcher or a community partner, get with your colleagues and submit your abstracts for presentation. We always have a really good spread of posters, and we feature 3 or 4 of these submissions for oral presentation. It'll be similar this year. We're in talks with a speaker to come in and share their expertise on health equity and community-based research, and we'll identify them soon, hopefully. And then also, uh, we have several awards that we give out every year. We have an early career community side and academic side award, and that's people that are within 10-ish years of the start of their engagement in their work. We have a community academic partnership for a duo of a community partner and a researcher who've been working together. We have an award for the E. Hill Deloney Community Champion, and then also an academic side award of a similar nature called the Toby Citrin Award. And so whether you are on the research side or the community organizational side, please consider nominating your colleagues or yourself, I think, for these awards. The links should all be on the HFRCC website. And yeah, and I wasn't actually looking at the slides here, I was looking at my own notes. So these all look great. And so, yeah, thank you for putting those together. And or if I did see Yvonne and Tanya on the call, so maybe you all sent those slides on, but that's what I have to share.
Awesome. Thank you, thank you, thank you. I love that we have the E. Hill Deloney Community Champion Award. What a honor. Awesome. Thank you so much. And deadline to nominate someone is August 26, 2025. I know some of you all can see the slides, but I know some of you are calling in. So if you've got someone that you want to nominate either for the early career awards, community academic partnerships, make sure you get your nominations in wonderful symposium, and we'll look forward to hearing who the speaker gets to be. Dick, who do we contact if we have questions?
You can email info@hfrcc.org. You
Info.
can email me if you want. I can put my email in the chat here. sadlerr@msu.edu. And I don't know if it shows up for everybody actually. So
No, I think it did.
cool.
All right. Thank you so much for that. I want to shout out a few resources that Doc G also put in the chat. So if you're trying to reach the Veteran Services line to learn a little bit more about the resources she represented, that number is in the chat as well. And then she has put the website for veterans who are suffering from Agent Orange exposure in the chat as well. So we've got those resources for you. All right. There's one other event that I want to talk to you about before we bid you adieu. So we have an event called the Organizational Succession Planning. This features Paula Murray. She's the Chief Human Resource Officer for the Frost Arnett Company, which specializes in healthcare financial services. She's going to cover developing a succession plan, aligning succession planning with your organizational and strategic goals, and identifying and accessing talent. It's super important to us that we're always bringing the community resources that we get to interact with to you and to the community. This is a wonderful event. It's going to be Friday, July 25th, 10 to 11:30, and you can access that via Zoom. This is being put on by our Master of Public Health Workforce Development Committee. So if you have time to check it out, please make sure you join. Again, it's Friday, July 25th, and we look forward to seeing you there. Last comment I wanted to make, and I think it's coming up here, if we go to the next slide, is a reminder for continuing education units for our community health workers. You get one CEU for every webinar that you attend. Also a reminder that our next webinar in August is of autism awareness, and September is going to be a takeover of the webinar by extension. We want to thank you so much. A shout out to Doc G, a shout out to Dr. Bianco for all of your wonderful expertise today. Remembering that public health is the health of the public, and therefore it's the health of the community. We are so well suited here in the College of Human Medicine, in the Department of Public Health, in the community, to be able to collaborate on all of the things that the community tells us that we need to understand and study more, and then be able to reach out to the researchers and the physicians and the nurses and the PAs and the pharmacists to be able to bring you that expertise. If you have things that you want us to know, if you have things you want to learn more about, if there's things we're not talking enough about, please do not hesitate to send us questions. The email is at the bottom. We want to know what you want to know about, so please let us know. Thank you so much, and we'll see you next month.
Thank you.
Great job, everybody.